Hello again. This is Alan Winter, and I'm here with my colleague, Dr. Charles Zelnick, as we continue our series discussing AI in medicine.
Good afternoon. We talked last time about various types of healthcare and how they impact scheduling in the office and access to your physician.
This week, we're going to discuss preventing death from a killer robot. And recall 2 weeks ago, we talked about healthcare as three models. In the case of value healthcare, which are diseases that are known signs and symptoms and are easy to diagnose, we said that the AI could really help us with these illnesses, speed patients through the system by screening them for these diseases earlier. And 2 weeks ago, we discussed how network healthcare or chronic disease health problems could be managed with our nurse practitioners and physician's assistants in concert with AI. And this week, we're going to talk about solution healthcare, which, as you recall, we discussed needs a doctor in the loop or an experienced clinician. And today we're going to find out why that's important and why these types of illnesses AI will play a very minor role in the treatment and diagnosis, because these types of illnesses are complex. They have a complex differential diagnosis, hard to treat. The resources are unknown. Time to care is uncertain. The cost is unknown. These are tough illnesses, and therefore it takes a lot more time. So, in order to think about these illnesses, we have to discuss how physicians think. So we know that doctors and clinicians of all sorts humans in general, do high-level integrative thinking very, very well. We can't remember a lot of facts as easily as computers. And in fact, computers can do a lot of low-level thinking very fast, much faster than us. Computers can create lists much faster than we can think about them. They don't do high-level integrative thinking as well as humans do. And we're going to see how that impacts care. So how do doctors think? First, they gather the data. So when you go to the doctor, the first thing that happens is the doctor interviews you. What can I do for you today? Oh, my nurse said you were coughing and have abdominal pain. And the doctor goes through a series of questions, but the patient may interrupt. I mean, he may say, have you had this tummy pain before? And oh, you're taking a drug. The patient may interject having taken a drug. And then do you have something else like vomiting? And then the patient will move the topic to, oh, can you look at my tonsils? And it can go in various directions that are pretty disorganized, and yet the patient and the doctor conversation is not in a straight order, as we see. So sometimes the doctor will go off and the patient leads into the aspects of foods, or the doctor, I want to feel your tummy to make it sure it's okay and prevent and do an exam, but he or she may also be taking history at the same time. So the doctor interview is data gathering, but it can be lengthy, and a lot of information may be gathered that's not helpful, or at least at the time. So the AI can gather this data better. And the way it does that is we can enhance the doctor's interview with a piece of smart software. What symptom do you have today? And it could answer questions. And then each of those questions, however, do you have abdominal pain? It could go into all the details about the pain. Well, where is the pain? Oh, the upper right side or the lower right side. How long have you had the pain? Oh, you've had it for a couple of weeks. Have you had it before? And so forth. And you see how the interview with AI could be extremely complex, even going into detail with standardized instruments that, for example, if the patient said that their abdominal pain got better if they drank alcohol, then you might um, want to do an alcohol screening test because that's a fairly unusual symptom, and that would reveal more information in great depth. And we see then the interview could be pro, projected to the doctor in a way that's very organized. And this, for patients who may not recognize this format, is a standard medical record format that can be generated by patient interview systems, showing the doctor exactly what symptoms the patient has in an orderly fashion that will allow she to think about the symptoms that the patient's presenting with. So then the step two in how do a doctor think is considering the causes. Now, here are just the causes of acute or immediate abdominal pain. And maybe the doctor takes the history and checks off about 4 of these as thinking, well, this is the most likely things that I'm going to think about. So that's sort of a running or working diagnosis as we think of making a differential diagnosis. And it may not be these because there's rare diseases as well, but this is how the doctor starts to think from that gathering the history as he goes along. And you see, this is how the differential diagnosis kind of comes together. Whereas he or she is thinking about appendicitis, gallstone disease, maybe inflamed stomach, but also the doctor doesn't want to miss the aortic abdominal aneurysm, very rare, but very deadly, a perforated ulcer where the patient could get peritonitis, or a ovarian cyst in the case of a female, and as well as having a testicular problem that's referred pain up into the abdomen. So there's lots of things that we have to consider. Well, the AI can make these diagnoses as well, creating lists. So the AI can help us with showing us the high probability diagnosis, then maybe the gynecologic diagnosis, the other gastrointestinal causes, and the rare diseases like referred pain. So the AI can give us these sorts of lists, and now it helps me think about, oh, the patient definitely doesn't have this, or I can refine the diagnosis. So now I'm refining it a little bit more by using some testing, maybe some imaging, completing my exam, maybe ordering a lab test, and working to expand the differential while being aware of unusual and critical or urgent causes. But the AI can help us too. So the AI might suggest some laboratory workup. And I can say, yeah, the C-reactive protein, that's number 2, that could be helpful. But I don't think it's an inflammatory disease. I think this is a different condition. So obviously we could select these tests, or it gives me an idea of maybe some things I might not have thought of for a few minutes and have to circle back around. So it organizes my thoughts in a way that could help me treat the patient more efficiently, and also help me to continue to work with the patient in thinking about the diagnosis. So then step 4 is to kind of refine the diagnosis. Because of the elevated white count, we might think more about appendicitis, or after the exam might consider the fact that they're tender in the lower right quadrant. And we basically ruled out or decided it's probably not gallbladder disease because it's in the wrong area, and the history's not quite right. And therefore we would change our thinking while we're working. And again, the more detailed and the more complex this gets, the less the AI can help us. So now we have to make a plan. And certainly If the patient has appendicitis, we should consider a surgical consultation after appropriate imaging. And that's how a doctor thinks about about a differential diagnosis. And I think we could safely say that it's it's hard when you consider being a doctor. Wouldn't you agree, Charles?
Yeah, and let's talk a little bit about how the how this works with the doctor and the patient. So the AI can help us make the lists, and it can be very helpful at helping us not forget things. One of the things that I used to teach the young clinicians when I was teaching the residency was not to make the list too broad, but also not to narrow down too quickly. You don't want to forget that aortic aneurysm in your first pass. You want to keep that on the list until you're pretty sure that that's not going to be the cause of the pain, because that could be deadly. Um, and when you get this history that's presented to you by a computer, and I've certainly had this in practice when I was using a history taking program, what I would do is come in and sit down with the patient and say, thank you for working on the computer with me. Thanks for giving us all this information. I know it took you some time. I've reviewed it all, but I want to hear in your own words what's going on. And this is really important, and you'll get back to that sort of winding path again, where the patient may say, "Well, yes, this has been hurting me really badly," and patient A may come to you and say, um, "I'm really upset about this. I've got my daughter's graduation in 2 days. I can't be sick. I've got to drive her and do all of these things, and yet I get this abdominal pain, and I threw up my breakfast, and something's really wrong here, and you've got to fix it for me right away." Um, Patient B may come in and go, this is not a bad time for me in my life. I'm not under any stress, but I'm really worried about this because when my mom had a pain like this, it turned out it was ovarian cancer, and they opened her up thinking it was appendicitis, and she had cancer everywhere. So that's a whole different psychological setup. And patient C may come in and go, I'm just overwhelmed. Now I've got this abdominal pain, and I'm hugely in debt. I'm in danger of losing my house. I don't have enough money to feed my kids, and I had to get a friend to bring me to the office today, and I've got all these social issues that are interfering with the care. So that's why you really need a human in the loop, because the AI is not going to know any of those things.
So the doctor has to deal with all of these different aspects of thinking through to come up with the diagnosis, and then has to add the additional uh, problem of the social aspects of health.
And the social aspects are very important, because we know that the difference in health status between patients and if you look at between counties, the health problems you see in one county are 40% determined by people's social determinants, compared to other counties. So you may live in a very safe place, you may live in a neighborhood that's not safe. You may have easy transportation in one community. You may live in a rural area where it takes you 45 minutes to get to the doctor, and that's on a day when it's not snowing. You may have supports from your church and your family, or you may not have those kinds of supports. Housing may be a problem. Discrimination may be a problem. These are all things that impact people's health, and they tend to be the things that doctors know intuitively about their patients, and it goes into your head when you're thinking about those diagnostic possibilities and also about the treatment plan. But the AI is not going to know that. It's not something that's going to be picked up by a questionnaire.
Absolutely. I think the knowing the patient, which we've talked about before and I've written about in my essays, it actually helps the quality of the care because the doctor can put things in context. And one piece that we haven't even approached is denial. A lot of people will deny a certain condition, or they may say, I don't want treatment for this, or I I think I can get away without that test because it costs too much,
Yeah.
and various reasons of saying that they may not want to pursue the diagnostic workup to get the diagnosis correct because they're worried about some of these social issues that AI is going to put down the list and recommend the test, but if the patient won't agree to get it, that's a whole different um, problem that physicians have to work with, and AI is not going to help with that. I think when you combine the social aspects of health with the additional problem of the longitudinal care of some of these people who have recurring problems of different types that become complex and they all interact, then it really becomes a question of how can I uh, consider all these things.
This is a journey map. This is just a mapping or a list of episodes of care or contact with the healthcare system of an 80-year-old man who saw a hip surgeon and decided with the surgeon that he needed to have a hip replacement. Um, and this shows the complexity of care that primary care doctors end up being involved in. So he had the hip replacement. He just a couple days after that, he ended up a couple months after that, he ended up in the emergency room with a possible stroke. He was then having problems with his recovery. He ended up seeing pain management, his primary care doctor, an emergency doctor, going back into the hospital for the hip pain, and finally ended up being discovered to have an infection in that hip replacement about a year after his initial surgery. He was sent to a skilled nursing facility after he had the hip revision, and after 2 weeks, he was his insurance company said, "We're not going to pay for this anymore because you're not making progress with physical therapy." And yet the surgeon had said he couldn't put any weight on his hip or try to walk for 6 to 8 weeks after his surgery. So there was no way he was going to make a lot of progress. So there was a lot of phone calls and going back and forth according to this patient's chart because of the insurance company wanting to discharge him. Then they had some difficulties with his medication. He was fainting in the assisted living facility. He had to go back to the hospital for that. His family doctor was involved off and on with these things. And then finally, he had a care manager involved to try to help work with the payment issues and getting his care in a timely manner and making sure he had all his medications correct. Then complicating all this, he ended up with heart problems and had to have a pacemaker put in. And finally, about a year and a half after the initial surgery, he had the right hip replaced again. And then there was still paperwork going on with the appeal for the discharge for not making progress in physical therapy. So it's a very complicated problem. There are lots of messages going back and forth between all the offices. And when you're seeing this patient, it's important to know not only, well, yeah, he's having pain in the right hip and he's having trouble walking, but you need to know all these other issues that are going on. His wife is the only one caring for him. He doesn't have any support at home or any caregivers or nurses' aides. They couldn't afford nurses' aides to help him at home. That's why he had to be in assisted living. He was having difficulty taking his medications on time. There are lots of things that have an effect on whether he's going to go back in the hospital now or later, or have another complication, or even be able to get his prescriptions and follow the treatment plan. And these are the kind of things that are not quantifiable. They're more intuitive, and yet they make a huge difference in the outcomes of patients' care.
Absolutely. And when you think about how AI can take facts and return facts, these facts are not clear cut. They're very nebulous and, if you will, fuzzy, so that they can't be quantified very easily as discrete data points, because they change almost hour to hour in terms of what the patient's status is, and you really can't expect the AI, after generating a list, if you can't complete the list because of all these other factors, then you have to make a judgment about which things are important and what's going to be the best care of the patient. Maybe not optimal, but it's the best you can do in the circumstances you're given. So the circumstances and context of all this data is important, and it's not reflected in the health records, because often there's no place in the records to keep much of this information. A lot of times the doctor who's made a home visit, for example, keeps a lot of this in his or her head, and that's why it becomes even more difficult sometimes. But there's even one more um, aspect to consider, and that's the family systems. And I don't think any electronic health record even will do anything like this. Have you seen one that'll do it, Charles?
No, I never have. And what you end up with most electronic health records is just a list of, grandmother had breast cancer and father had heart disease. But we learned to do this in residency on paper back in the old paper systems, and it was extremely helpful. And the first 10 years I was in practice on a paper system, we had this on the left-hand side of the chart when you would open it up. Because at a glance, this shows a clinician not only the illnesses that run in the family, but you make notes in there and about, this marriage is under stress, and they're thinking about having a divorce, but the woman that's in front of you, she gets great support from her grandmother on her mother's side, and her brother who lives in town and he can help out. And so you can write in some family dynamics and family systems as well. And then each time you open it up, it's an instant refresh for your brain about what's going on with this family in terms of their family system. And as a family medicine doctor, I got to say this is a really important thing, and the kind of thing that is really hard to get into chart or get into your head until you've seen a patient several times. So it's nice to have it documented, and I wish there was a way to do this electronically and see it right at the top of the chart when you go to review things.
Certainly, we've all had the experience and realized that electronic health records were really not made for doctors to take care of patients as much as to collect the bill. And as a result, it shows when doctors try to use them. But that's not to say that we can't change the system by having the AI help the physicians to complete the billing requirements of the system. And I think that's where we're going to be going in the future with helping to improve the documentation. We're going to talk about that next year. But putting all this together, Charles, it's easy to see why a robot AI doctor is not going to be the answer to many complex problems. And the problem is the patient may not realize what is a solution healthcare problem and what is just an exacerbation of a chronic health problem, and what's a value health problem, because they can all look the same if you're not trained to understand what medicine means and how it's practiced.
Well, I think this brings us, now that we've talked through the diagnostic process, we can kind of go back and look at what the chatbots are doing. And this case recently came to my attention in the New York Times, where an AI chatbot became a killer robot. And we talked at the beginning of this series about how important it is to have trust in your physician. And in this case, a very educated gentleman, a neuroscientist, had been treated with lung cancer with his physicians, and he had had a lot of frustration, and of course nobody would be happy having to go through lung cancer treatment, and he'd been treated successfully and his lung cancer was cured. But he had also carried chronic lymphocytic leukemia, which is a smoldering kind of leukemia that people can have for decades, and it may not make them sick or kill them. But after his lung cancer treatment, this CLL, this kind of leukemia, started getting a whole lot worse, and his cancer specialist said to him, listen, we need to start treating this. The gentleman, unfortunately, was very unhappy with the medical system, and he started researching on his own with a chatbot and putting in his own symptoms and his own history and telling it that he didn't really want to have this treatment and that he really needed to have it. And the chat box just kind of went down the rabbit hole with him and kept saying, well, maybe you don't need to have this. Maybe you have something else. Maybe you have a rare disease, or Ritter syndrome that nobody'd ever heard of. And it got to the point where he was going back to his oncologist, his cancer specialist, with the printouts from his chatbot, and arguing with the chatbot was arguing with the oncologist, with the specialist, that he shouldn't have any treatment. And his lack of trust in his oncologist, and his believing what the chatbot was telling him led him to delay his treatment for over a year. And by the time he finally did start treating this leukemia, it was too late, and he rapidly became more ill and died. So I think this is a really good case of the chatbot becoming a killer robot, and it highlights the inability of the AI systems that we currently have, and particularly chatbots, to have enough of the information to get a sense of what's going on with the patient, to have all of the facts and have some judgment or that higher level analytical thinking that's saying, what is the risk here? What are the risks and benefits of treatment? How do we know for sure that the diagnosis that we're working on, the CLL, is the correct diagnosis? Those are all things that physicians train for years to learn how to make that judgment. And then it's really important that the physicians have those conversations with the patient in a trusting relationship, so that the patient can go ahead and do what needs to be done with trust and faith, that even though the process may be painful or difficult or not a happy process to go through cancer treatment, it's going to help them live longer and live better than if they don't do anything.
Yes, I would certainly encourage everyone to read the article. He warned about the dangers of AI. If only his father had listened. It was published on May 6th by the New York Times, and it certainly explains what we've been talking about. So I think that explains how hard it is for doctors to make diagnoses, and why you probably don't want to use an AI system to try to treat yourself, because the results may be tragic. Our next session is going to talk about how we can put all these pieces together and try to make the doctor more efficient in every way, as we look at how we can increase doctor productivity in our next session. So, Charles, I want to thank you again for helping out, and I'll see you next week.
Very interesting topic. Thank you very much.